مساء الخير، كل عام وانتم بخير. We have a case-based scenario session, and I hope to be interesting. Let me start with first case. Middle-aged patient, diabetic, on metformin 500 milligram twice daily, with body mass index more than 30. That means patient obese, presented with central chest pain and diaphoresis. Time to arrival to CCU 60 minutes. Vital signs at the presentation. Blood pressure 120/80 and pulse 74 beats per minute. What next step in such case? The next step on such case with chest pain, central chest pain and sweating, and he have a risk factor, diabetes and obese. The next step, ECG, cardiac marker, cardiac enzyme, and other investigation. What about ECG? We show this ECG. ECG found sinus rhythm, heart rate around 80 to 100 beats per minute, axis, left normal axis. There is an ST elevation in lead 2 and lead 3 and AVF, with the reciprocal changes of lead 1, AVL and V6. In addition to prolonged PR interval, we found the prolonged PR interval, that means first degree heart block. Collectively, this patient suffer from STEMI, that means myocardial infarction, inferior myocardial infarction, inferior myocardial infarction. Sinus rhythm, heart rate 84, normal axis, borderline first degree AV block, signs in the inferior lead 2, 3 AVA reciprocal changes. This is the finding. Collectively diagnosed patient with inferior myocardial infarction. What need next? Need cardiac marker to confirm the diagnosis, troponin and CKMB, in addition to other cardiac markers like LDH and myoglobulin, but definitely troponin and CKMB is more valuable in such cases. Troponin will be positive after 6 hours and remain high for 14 days, and CKMB elevated within 2 hours and the peak within 12 to 24 hours and subside and reduce decline after 2 days. Other investigation might be needed in such cases. Might be need cardiac, in addition to cardiac enzyme, a white PC count, ESR, C-reactive protein, lipid profile, low density lipid, high density serum cholesterol and serum triglyceride. Also, we need blood urea, serum creatinine, liver enzyme, in addition to the random blood sugar and hemoglobin 1AC, because our patient is diabetic. How manage such case? Should start with dual loading dose of aspirin and antiplatelet clopidogrel, 300 milligram aspirin to 300 milligram clopidogrel. Also, we need low molecular weight heparin or heparin for 2 to 7 days, according to the body weight. Lipid lowering agent like rosuvastatin and the trade name Crestor. Sometimes need painkiller, morphine and antiemetic, because side effect of morphine is vomiting. Oxygen if indicated, and beta blocker if the pulse rate high, and AC inhibitor if the patient hypertensive, or if the patient, our patient, compensated hypertension, or might be used even in patient not hypertensive to prevent remodeling of the cardiac muscle to prevent heart failure in such cases. And the physician at the time before start thrombolytic or PCI according to the window time, because he's arrived to the CC within 60 minutes, that means might be PCI, primary catheterization, is a priority, but still, if there is no catheterization backup, you can't give a thrombolytic. But our physician in such case, because patients suffer from chest pain, give him Angised sublingual. And when he give him Angised sublingual, at the time, patient develops suddenly severe bradycardia and blood pressure drop from 120 to 80 over 40. So what is the explanation of such development? We return back to the ECG. What other finding we are missed? Again, the ECG found, as I mentioned, normal axis and the sinus rhythm, but there is ST elevation lead 2, 3, AVF, and reciprocal changes lead 1, and AVL and V6, but we missed an ST elevation in V1 and V2. This ST elevation is important because this ST elevation in such case give a clue to other infarction might be associated with inferior myocardial infarction. So ST elevation in V1 and V2 and ST elevation in lead 3 more than ST elevation in lead 2, that concluded as a case of right ventricular infarction might be associated with inferior myocardial infarction. So how confirm the diagnosis of right ventricular infarction? We can confirm the diagnosis of right ventricular infarction, but shift by shift the lead of the ECG from the left side to the right side. That's what we call V4R. That means right side V4. That means traditionally or normally we did the ECG and put the V1, V2, V3, V4, V5 in the left side. Shift those lead to the right side, and that will be beneficial to expose the ST elevation in V4R. This diagnostic for right ventricular infarction, if compared with the first ECG, there's no ST elevation in V4 and VR, but when change to the right side, we found ST elevation in V4. That was we called V4R. So patient in such cases do another ECG from right side to confirm the diagnosis of right ventricular infarction. So the right ventricular infarction is associated around 25% with inferior ST elevation myocardial infarction, and mostly of this infarction of the right ventricular infarction and inferior myocardial infarction due to right coronary artery occlusion. And those patients with such history or such scenario are sensitive to the preload and sensitive to the drugs which be reduce the blood pressure like nitrate. And developing of exacerbated hypotensive response to the nitrate is a clue for diagnosis of right ventricular function. What is surprising in such history and such scenario and such management is the line of treatment of such cases is a fluid. You should give your patient 2-pint fluid normal saline in addition to what I mentioned before, and should avoid nitrate, and in addition to prepare your patient for primary PCI to solve his problem. So in conclusion of such case, any patient with inferior myocardial infarction should put on your mind an association of right ventricular infarction. And the clue for diagnosis of right ventricular infarction by normal ECG is ST elevation in V1 and V2. And the confirmed diagnostic test is a V4R. And in addition to management, traditional management used for myocardial infarction should add a fluid, 2-pint, and avoid beta blocker and avoid nitrate in such case. This is the first case. Okay, let me share with you a second case. Second case, 30 years old patient presented with generalized weakness, high blood pressure, his blood pressure 160/100, in spite of medical maximum and tolerable antihypertensive medications. That means he received 4 drugs, 4 groups, and maximum and tolerable. In spite of all medication, the patient still have high blood pressure. That means our patient still has resistant hypertension. But our patient developed weakness. And what the explanation of the weakness of such case might be side effect of a drug, might be due to hypertension per se, might be due to electrolyte or other. What you're suggesting in such cases, look for diuretic, because diuretic can cause weakness, and the cause of weakness in diuretic because loss of potassium, sodium, magnesium, calcium. So the electrolyte per se can induce weakness in patient with hypertension and receive a lot of drugs might be contributed in electrolyte variation. Our patient, this ECG for this patient, and what finding, obvious finding in such ECG. Also, this ECG shows normal axis, sinus rhythm, heart rate around 80, 70 to 80. But what obvious? The obvious is a prolonged QT interval and a prominent U wave. So the main abnormal, positive deflection U wave and prolonged QT interval. Those findings suggestive of severe hypokalemia. And to confirm the diagnosis, sent for serum potassium, and the result was 1.7. So our patient, resistant hypertension and severe hypokalemia. Those two entities, resistant hypertension and hypokalemia, put the diagnosis of endocrine at the top of the list. So any patient with resistant hypertension and hypokalemia should put on your mind diagnosis of Conn's syndrome, what we called primary aldosteronism. What is primary aldosteronism? High percentage of those patients presented as a resistant hypertension or refractory hypertension. And the most common cause of primary aldosteronism either adrenal adenoma or adrenal hyperplasia. So aldosterone hypersecretion, which act as on cortical collected duct to stimulate potassium secretion into tubular fluid and enhance renal and urinary potassium wasting. So normal mediators, or what system mediate the aldosterone? The aldosterone controlled by renin, serum potassium, serum sodium, intravascular volume status, and corticotropin. So patient with hypokalemia and hypertension and weakness might be presenting with abdominal distension, ileus. In general, collectively, those patients is Cohen syndrome, and the line of treatment of those cases, either pharmacological therapy or surgical. Pharmacological therapy include calcium channel blocker to control the hypertension, in addition to ACE inhibitor or angiotensin receptor blocker. The main line of treatment should avoid diuretic as possible, and can add mineralocorticoid antagonism in the treatment and glucocorticoid in the treatment. So, conclusion of such case, any patient, young age, with hypertension, resistant hypertension. What I mean by resistant hypertension? Those patients receive four drugs, including diuretic, without response. Those four drugs in maximal tolerable dose, without response, should put in your mind the diagnosis of resistant hypertension. Any patient with resistant hypertension and hypokalemia, can this hypokalemia diagnosed by serum electrolyte or can diagnosed by the ECG, which confirmed by the U-wave and prolonged QT, put on your mind the diagnosis of endocrine disease, Cohen syndrome. And thank you very much for your listening. And I hope this session will be beneficial to you. Thank you very much.